Welcome everybody to our Google Hangout today. This is the second time we've done this. For those of you who are with us for the second time, thank you for coming back and trying this with us again. First time we did it was with Nora Super, who's the director of the White House Conference on Aging, and you can see that on YouTube. But we had some sound issues with that one and some other technical difficulties that we hope we have worked through today. We also have our guest, who's also an employee at the Medicare Rights Center, with us on camera. So you'll see two people on camera, myself and Stacy Sanders, who's our federal policy director and who's based in Washington, D.C. Stacy is, in short, our woman in Washington, who knows all about what's going on in federal policy, both congressionally and regulatorily, the administration, about Medicare. She keeps us in the know. She represents your interests if you're a Medicare beneficiary and Medicare advocate, and certainly looks out for where the Medicare Rights Center can be most effective in Washington in accomplishing our mission, which of course is to make the Medicare program as responsive as it can be to the needs of the people that depend upon the Medicare program, all of those folks. So today we're going to talk about what's going on, particularly in Congress at the moment, because it's been in the news. If those of you that read the New York Times, you'll have seen an editorial by the Times today, in today's paper, about what's called the doc fix, or the legislation that's moved from the House to the Senate to change the way doctors are reimbursed under the Medicare program. Does a couple other things. We're going to talk about that in a moment, because that's kind of, if not front page news, then editorial front page news at the moment, while the Senate's on recess. But I wanted to start with the budget and ask Stacy, basically, what's going on with these budgets? What's happening right now in Congress? What's in front of the policy agenda in Medicare? And particularly, what these three things are, and then we'll move ahead kind of to delve deeper into them. So Stacy, maybe you can just tell us, what's on the plate now for Medicare in Congress.
Sure, yeah, and it's great to be here today. I'm looking forward to everyone's questions. So really in Medicare, Congress is looking at three different things right now, or there's sort of three pieces of policy that we're closely following. And the first, as Joe mentioned, are the budgets. So the House of Representatives introduced and passed a budget in March that includes some pretty major changes in Medicare. Similarly, the Senate introduced and passed a budget resolution that also includes some significant potential Medicare changes. And then lastly, and this was a little bit unexpected, the House of Representatives worked on a piece of legislation that would permanently change how we pay Medicare doctors. And that has a number of important implications, both for Medicare physicians, but also for beneficiaries.
Right. So maybe, Stacy, we'll start, with the money. And I know that the budgets have kind of taken a backseat to the doc fix, which we're going to talk about. But maybe you can tell us a little bit about what's in the House and the Senate budget at this point.
Sure. So in the House budget, what you see for Medicare are cuts of over $140 billion over 10 years. But perhaps more important than that, the House budget really restructures the entire Medicare program and how it would be provided to future Medicare beneficiaries. The House budget includes something called premium support, or a voucher program. And in introducing this program, essentially future beneficiaries, so new retirees and people with disabilities, would receive a payment to buy a Medicare insurance plan on the private market, a lot like what we have in Medicare Advantage right now. However, this would be extended to all Medicare beneficiaries. Another thing the House budget does is it redesigns the traditional Medicare benefit. So in traditional Medicare, you have a deductible and cost sharing for Part A, the inpatient or hospital care. For Part B, your outpatient care that you receive at regular doctor's visits, and then separate premiums and cost sharing for Part D and prescription drugs. This re-envisioning, or sort of restructuring of traditional Medicare, would combine Medicare A and B under one deductible, would revise the cost sharing that currently exists in Medicare, and would add an out-of-pocket maximum to the traditional Medicare benefit. The Senate budget, so that kind of is some of the major details that are included in the House budget. The Senate budget identifies a target number of savings in Medicare of over $430 billion. But it's different in the House budget in that it doesn't actually name what those cuts would be. It leaves it up to the congressional committees to decide how to cut Medicare. Again, looking at cutting $430 billion over 10 years.
Okay, so basically the House budget, this House budget, is similar to the House budgets in the past that would institute a kind of premium support or voucher program. And the same concern is that you would get a limited sum of money, a voucher, that you would then be able to go on some sort of private insurance exchange and buy your Medicare coverage there. And once again, the fear would be that the amount of that voucher would not necessarily keep pace with the cost of insurance that might be available in that private exchange. And so therefore, overall, people would be spending more out of their pocket for their Medicare coverage. Do I have that right?
Yes, that's right.
Okay. And the Senate budget takes a lot more savings out, but doesn't really talk about where they're coming from. I heard that from you. But we would expect that there would be a considerable amount of additional cost sharing or other costs loaded onto beneficiaries in the Senate plan as well.
Yeah, it's hard to imagine how Congress could cut over $400 billion out of Medicare without in some way shifting additional costs onto seniors and people with disabilities.
Okay. And I know the president came out with his budget before both houses came out with theirs. Maybe you could just run down what his approach is for Medicare.
Sure. Yeah, so before the House and Senate introduced and passed their budgets, in late February, the President released his budget, his framework, and set of priorities for Congress. And his budget also had very significant Medicare savings, but also made some key investments. Most of the President's Medicare savings come from securing lower prices on prescription drugs. That would be done through a number of different ways. The first would be to allow Medicare to benefit from some of the same discounts on prescription drugs that exist in the Medicaid program. The second would be to allow the federal government to negotiate prices, specifically for very high-cost specialty medications, and then a few other prescription drug proposals. But still, the President's budget does include some policies that would shift higher costs onto Medicare beneficiaries through higher premiums for some Medicare beneficiaries and higher deductibles and copayments for others.
Okay, and I think some of the President's proposals with regard to deductibles, at least, are in the doc fix legislation as well. I mean, I know we'll get to that, but am I correct about that?
Yeah, a version of those, yes.
Okay. So what I know we're going to talk about the doc fix, and that seems like what's really going to happen next. But vis-a-vis the budget process, which I know has been a kind of torturous process over the last few years with, not an entire budget necessarily being enacted, but rather continuing resolutions or specific departmental budgets. What looks like the way, these budgets could move forward over the course of the next, let's say, 6 to 8 months?
Yeah, sure. So, yeah, that's true. Over the course of the last several years, Congress hasn't followed its sort of traditional process for flushing out a budget in the Congress. However, this year, it's looking like that's shaping up a little bit differently, and Congress will follow what's called regular order. So at the moment, what we have is a House-passed budget and a Senate-passed budget, both which reflect Republican priorities. But as I mentioned, there's differences in those budgets. So at the moment, Republican leadership in the House and the Senate are working to reconcile the differences between those two budgets. And once Congress passes a final budget that's reconciled, the same in the House and the Senate, essentially they provide instructions to different committees in Congress who will then work on how to fund different agencies and different programs. For Medicare, what we expect is that there will be instructions that are called reconciliation instructions that essentially tell the appropriate committees in Congress to find Medicare savings under a certain target number that's decided in the final budget.
Okay, we lost you for a second there. I don't know why, but I think we got the gist of it, Stacy, which is basically, or lost your audio at least. And now we're about to have the fire trucks go by here in New York City. When you work and have your offices in Midtown Manhattan, and you can't afford a sound stage, that's completely quiet, you have to have a little bit of local color come by every once in a while. We'll hope it's not a real emergency, but in any case, they do get through eventually, and then the noise stops. But hopefully you can. That's them. There they go, up 8th Avenue. In any case, I think what we're hearing is that the general procedure will be for Senate and House to reconcile their budgets, come up with one budget, and then the Congress to debate that through the committees, and then as a body as we move forward over the course of the summer or in the early fall.
Exactly.
Okay, great. So I know we've been talking about the doc fix, and I think a lot of our viewers and folks that are out there know what this is, particularly if they followed Medicare over the last decade, because it seems like every year, sometimes even more frequently, we hear that Congress has got to do the doc fix, and there's a lot of brinkmanship around this. Basically, if the doc fix weren't to happen, there would be a 20-odd% cut in physician reimbursement under Medicare. Doctors would leave the Medicare program. This is always used as a kind of political football. Tell us about what's happening right now with the doc fix. We know the Senate and Congress are in recess for the Easter holiday, but what's the state of play right now?
Yeah, so essentially what we have is a bill that has passed in the House of Representatives that would once and for all permanently replace what's known as the Sustainable Growth Rate formula. And this was a formula that was developed in 1997 that essentially determines how Medicare physicians and other healthcare providers get paid. And for a very long time, there's been really universal agreement across the aisle, across all affected stakeholders, that the SGR is flawed. It's not a good way to decide how we should pay Medicare doctors and other healthcare providers. And for a long time, as Joe mentioned, Congress has sort of annually patched the SGR formula through what's known as the doc fix. But once and for all, what we finally have is a package that would repeal the SGR formula and replace it with a new system for how we pay doctors and other healthcare providers, one that's based on value as opposed to on volume or the number of services that are provided. For a very long time, the real crux of the problem, the reason that Congress couldn't move forward, was because they couldn't agree on how to pay for repealing the SGR. It costs $140 billion over 10 years to kind of once and for all do away with this flawed formula. But 2 weeks ago, the House of Representatives voted on a bill that would permanently do away with the SGR, create a new way for paying Medicare doctors, and they also agreed upon a way to pay for this legislation.
So sounds like pretty good news for people with Medicare, because we know here at our Medicare helpline, in our national helpline, every time this doc fix was getting debated year in, year out, or sometimes more frequently, we get calls from worried seniors and other people with Medicare saying, my doctor told me that his reimbursement's going to be cut and he's going to have to drop me as a patient, or he's not going to take any new Medicare patients, or he's just going to leave the Medicare program entirely. So it sounds like fixing this doc fix, fixing this reimbursement formula, is a good thing overall for Medicare. But I know there are some factors in it that folks have been a little bit concerned about as well. Maybe you could tell us a little bit about those.
Yeah, sure. So yeah, it's absolutely a very good thing that Congress is once and for all replacing or planning to replace the SGR, because it does give both physicians who receive Medicare payments and see Medicare beneficiaries, as well as the beneficiaries themselves, some real security and peace of mind that's been missing for the last decade. But there is some bad news, because, as I mentioned, the real hang-up to finally fixing the SGR once and for all had been, how do you pay for the package? And Congress, in this legislation, the House of Representatives, agreed to pay for part of the package, and part of those costs come directly from the pockets of Medicare beneficiaries. So some Medicare beneficiaries will pay higher premiums, and some new beneficiaries will see a new deductible that's been introduced. And that is the package of savings that's partly being used to pay for this SGR repeal and replacement.
Right. And so what costs will go up, and who will be affected? Is this a kind of across the board, or does it affect some groups more than other groups? And what is that? How does that happen if it does push costs up for some folks?
Sure. So it is not across the board. Costs will not go up for beneficiaries across the board, but there really are two different sets of people who will be affected by these changes. The first is in 2018. Some beneficiaries who are already paying higher Part B premiums will pay even more. So in particular, people who are paying higher Part B and Part D premiums who have incomes of $133,000 per year, or couples who have incomes of $266,000 per year will now be paying higher premiums. Already, these individuals were paying higher premiums through a process known as income relating or means testing. And that means that the amount of your premium ultimately is tied to your income. And if you have a higher income, you're expected to pay higher than standard Part B premium of $105 per month. The second set of people who will be affected are people who are not yet in Medicare, but who will become eligible for Medicare in the year 2020. And these are individuals who may be purchasing a Medigap supplemental plan to go alongside their Medicare benefit. And for the first time in Medigap, they'll be introducing a new deductible into two Medigap plans. Medigap Plan C and Plan F traditionally had provided what was known as first dollar coverage. That means your Medigap plan paid all of your upfront costs, including your deductibles and your cost sharing, when you go to the doctor's office. Starting in 2020, this will no longer be true for people, again, who are new to the program. They will begin needing to pay the standard Part B deductible. Today, that deductible is $147. It's estimated to be about $180 in 2020.
I want to come back to the ramifications of that loss of first dollar coverage, because not only is it that deductible, but there's also, what the hope would be in the savings of, as we know, is that you would dampen down or decrease utilization of health care because people wouldn't have that first dollar coverage. So let's come back to that, because I want to finish off talking about the facts, if you will, of the SGR or the doc fix. I know that there are some things that every time the doc fix happened year in, year out, there were things that were added onto it that were called extenders or other kind of Christmas balls that were hung on its tree to kind of either take care of problems. So maybe you could tell us a little bit about if that's the case with this bill that's passed the House and is in front of the Senate right now, and what those extenders or additional pieces are that would become law as part of this SGR bill or a doc fix bill if it were passed.
Right. So yeah, that's exactly right. There are a number of what we refer to in DC as extenders policies that typically ride along the doc fix. And these are policies that they're not permanent policies. Every year are on a certain schedule, Congress has to act to reauthorize these policies. And there are really three important extenders policies that are really important to Medicare beneficiaries. And that includes the Qualified Individual Program. This is a program that helps some of the lowest income Medicare beneficiaries, people with annual incomes of about $14,000 to about $15,900 per year, and who also have very limited assets, cover the cost of their Part B premium. The second very important extenders program is the therapy cap exceptions process. So right now in Medicare, there's really an arbitrary cap that determines when a person can stop receiving physical therapy, speech therapy, or occupational therapy. And annually, Congress has acted to enact an exceptions process so that people can receive those therapy services above this predetermined cap. And then finally, the last and third extenders is funding for community-based organizations. And this includes state health insurance assistance programs, area agencies on aging, and others to conduct outreach to Medicare beneficiaries so that they're knowledgeable of and enrolled in some of the low-income assistance programs that they're eligible for. And that includes the Qualified Individual Program, the QI program, as well as others.
So these things are basically every time they did the doc fix, they would extend these things for a limited period of time, maybe the same period that they, extended the doc fix. What happens to these things now if the doc fix is going to be fixed permanently? Are all of these things, fixed permanently as well or extended permanently?
Yeah. Unfortunately, in this final piece of legislation, only one of these extenders policies dealt with permanently, and that's the Qualified Individual Program. If the bill that was enacted by the House becomes law, the Qualified Individual Program will become permanent. However, the therapy cap exceptions process and that funding for community-based organizations is only being extended for 2 years. And this means that, again, in 2 years, Congress will need to act to ensure that that exceptions process and that funding for community-based organizations is continued.
So I take it that it's important that those other two extenders, the therapy caps and the assistance for the assisters, as it were, is also made permanent because you won't have the doc fix coming up again as kind of the lever to make sure those things happen on a regular basis. So that's why it's important to make all of these extenders permanent if we can as the bill moves into the Senate.
Yeah, that's exactly right. I mean, the doc fix and the SGR have a sort of threat that Medicare physicians would have their pay cut by over 20%. As it provides a lot of political leverage and it provides a lot of pressure on Congress. So because Congress absolutely has to get the doc fix done, they can't cut Medicare doctors by 21%. It's sort of been a sure bet that all of these extenders policies would ride alongside the SGR. And I think there are some people who are worried that if the SGR is no longer in the mix, the question is, will there be the same political pressure and the same will among members of Congress to keep those extenders policies going and to reauthorize them now that they won't have to deal with the SGR.
Right. So this seems like, I mean, I know the House bill passed 392 to 37. So, I mean, this train is really whooshed out of the station with many folks aboard, is in the Senate. A lot of things that we've heard about the Senate is that there's a lot of support in the Senate once again for this. So maybe you could talk a little bit about what's going on in the Senate and kind of what we can do to make this bill more palatable to beneficiaries, not only extending these other extenders and making them permanent, but what can we do about some of these costs that are offloaded onto Medicare beneficiaries?
Yeah, sure. So that's exactly right. Next up, the bill is in the Senate. Right now, the Senate is in recess, so they're not holding any votes. But it's expected that the Senate will vote on this package as soon as they get back, around April 14th. So the question right now in the Senate is whether or not they'll vote on the bill as it was passed in the House, or whether or not they'll entertain amendments and consider opportunities to improve the bill. And right now that's an open question. There's a lot of pressure, I think, from both sides. Some organizations like the Medicare Rights Center, AARP, National Council on Aging, and others who represent Medicare consumers that really want the Senate to consider some amendments and consider some ways to improve this bill. There are others who really just want to see the bill pass, and they don't want to entertain any opportunities that might slow this legislation down. I think it's pretty much expected the Senate will approve the package. The President has already said that he will sign the package as it came out of the House. The question is, will the Senate take an opportunity to make the package a little bit better?
So what we would be advocating for, and I know we want our viewers to help us out here, and we'll get to that in a second, but what we're advocating for, and you'll correct me if I'm wrong, is we're very happy that the QI program, the Qualified Individual Program for low-income people, is made permanent, but we would actually like to see that increased to a higher level of income to 150% of federal poverty, so that not only it's permanent, but that more people and more people who are low income and really have trouble affording the Part B premium can pay for that. I think we also, if I remember correctly, want to make sure that the therapy caps, those exceptions, are made permanent so that folks can get access to therapy above and beyond those kind of arbitrary caps that are set. And additionally, we want to see the funding for the variety of programs that help people with Medicare continue and made permanent, and even increase in some instances. And then on the flip side, or if you, I don't know if it's the flip side or not actually, but on the side of costs, we would like to see this idea of, deductibles in Medigap plans, Part C and Part F, go away. We'd like that taken out of the bill. Did I summarize that correctly?
Yeah, I think, in an ideal world, we'd like it if the policies that shift additional costs to Medicare beneficiaries were taken out of the bill, and if all of the improvements that you just listed were also included. I think the sort of unfortunate political reality is that the cost shifting that's in the bill, those higher premiums and the addition of that new deductible in Medigap plans, is probably not going away. But we do think that there is a real window of opportunity for the Senate to make some improvements to those extenders policies, as you noted. And as you said, the priorities really are providing QI benefits to more people who are very low income, helping people who wouldn't otherwise be helped as a result of this legislation, ensuring that those community-based organizations have the resources that they need permanently to do outreach to low-income people around benefits, and then also repealing the therapy caps. So once and for all, sort of doing away with that bad arbitrary policy that sort of sets a cap on the kinds of therapy that people can receive. And I think just in general, as we've discussed, sort of once and for all, treating the extenders in the same way that we're treating the SGR. So once we're permanently going to replace the SGR, we should also have permanent solutions for all of those extenders policies that are important to people with Medicare.
Right. And I know we're going to talk, I'm going to ask you in a moment what our viewers can do. And we've got some information, not only we can tell them now, but we're going to have some information available on our website, etc. But I want to remind anybody that's watching or listening that you can submit a question through the Google Hangout, and we can try to answer that question, either clarifying question or other question. We're going to try to stick to the topic, but of course, if there are other questions, we either answer them and during the Hangout, or we can respond later offline. And our helpline is always available as well for those of you that may be consumers or professionals helping consumers. And I'll just shout that out right now, 1-800-333-4114. That's 1-800-333-4114. So you can feel free to call that helpline if you have a Medicare question or a Medicare issue that you would like help with. We're also available on the web at MedicareRights.org, as well as Medicare Answers at MedicareInteractive.org. So, but most of you know all that because you get our emails. That's why you're here today, most everyone. But Stacy, before we move to any questions that folks might have, what can our viewers do to influence this Senate vote before it happens when they come back on April 14th?
Sure. Yeah, so the most important thing that anyone who's listening to this call can do is call their senators and express that you want to see the Medicare Doc Fix bill improved for seniors and people with disabilities. You want, and you should say that you want the Senate to vote on an amendment to make the bill better. And in particular, ask the Senate to repeal the therapy caps and to take care of low-income Medicare beneficiaries as a part of the final package. So the best and easiest way that you can reach out to your senators is by calling the Capitol switchboard, and that phone number is 202-224-3121. Again, that's 202-224-3121. And we will be following up after this Hangout with an email for everyone who's listening today and for all of our subscribers that includes that phone number and also includes some talking.
So we've lost a little bit of audio, at least. This is the second time this has happened during our Google Hangout today. We're going to, as Stacy was saying, and we'll hopefully have her back on audio shortly, but as she was saying, we're going to be posting and sending in an email to you all some talking points that you can use with your senators. And we'll also include that number that you can call. And it's important to note that, and this may be in the email we send to you, that you have to call twice, or the best practice is to call twice. One time for one of your senators and the other time for your other senator. Because, as we know, every state has 2 senators. So that's going to be an important thing for those of you that feel this is an important issue to weigh in. Once again, the message can be as simple as we think the Senate should add amendments that sweeten this doc fix for people with Medicare by either helping the low-income beneficiaries or by also getting pay caps. Is particularly important after a stroke or other illness leads folks to need therapy. These caps are very arbitrary, very low. Exceptions are really key for folks getting access to care, to that vital therapy. So I know that Stacy is, I think, back with us, and we're going to take some questions that folks have. She can see them, I can't, so she's going to be the question asker. I might be able to answer some. We'll see. We'll find out. But between the two of us, we'll either be able to answer them or we'll get back to the questioner and the audience at another time through email or otherwise. Stacy?
Fell off. I don't know if you guys saw that, but I'm back. And actually, I cannot see the questions. So, yeah. So maybe do you guys in the New York office have access to the questions?
Yeah, we do. Mitchell's looking at them now. He's been looking. Mitchell's been toggling back between Washington and New York. He's been the control room. So Mitchell Clark is our senior communications associate, and he has dreamed all this up. So it's working much better from what we can see, and I hope you guys agree. But there are some glitches. But Mitchell's going to feed me the questions.
So they may not be able to hear me, but I'll feed them to you and you can read them.
Okay, thanks.
We may have touched on this, but one is the current House bill going to voucherize Medicare, and do you know any specifics, including but not limited to therapy caps and QI people? So maybe just a little recap on that.
Right. So one of the questions was about vouchering in the House bill. So yes, and the short answer to the question is the House bill does include a voucher program. Some of the details have not been sketched out. It's not clear that this is exactly like the bill that Chairman Ryan, Congressman Paul Ryan, when he was chairman of the committee, put forward, but it seems pretty similar. And it's pretty much the voucher program that we've been talking about and that the House has been passing in their budget over the last, I think, 2 cycles. And also that asked once again about the therapy caps and the QI, or Qualified Individual Program. The good news is in the House bill, the doc fix legislation that moved to the Senate, that there is a permanent extension, or it makes the QI program, the Qualified Individual Program, that helps low-income people pay for their Part B premium, which can be significant expense for them. It does make that program permanent. That's the good news. It only extends, the current bill, the therapy cap exceptions process for 2 years. And we are fighting that the Senate would introduce an amendment, and that's why we want people to call their senators, to make sure that that therapy cap exception is made permanent, that process is made permanent. Not only because that's the right thing substantively, but as we were saying earlier, politically, that always got done, that therapy cap exception process, as part of the doc fix. If the doc fix is actually fixed permanently, you don't have this little therapy cap exception Christmas ball, if you want to call it that, or ornament to hang to your tree, because the tree's done. The tree's not there anymore. It might be harder to get that therapy cap exception done year in, year out after that 2 years is up. So we want to make sure that this is made permanent, and we're asking folks to reach out to their senators and say, do an amendment making the therapy cap exception process permanent, and also making funding for the various programs that help people with Medicare get assistance across the country, make their funding permanent as well. And we're going to be sending an email with talking points about that. It'll also be up on our website.
Another one we have is, can't the president do something to stop all these proposed cuts to Medicare and Social Security?
So the other question is, can't the president do something? And I'll answer part of this, and maybe Stacy, you can take a piece of this. But the president has proposed a budget, as Stacy was saying. There are some things that one thing that he does that is very positive is he has a proposal to get a significant amount of savings for the Medicare program from the cost of prescription drugs, which we believe is a good proposal and would not affect access to prescription drugs. On the flip side, the president does have a variety of proposals. One is, and Stacy, maybe you can talk about those, that would push more costs onto people with Medicare, particularly those with higher incomes and those with Medigap. Stacy?
Yeah. So yeah, the president's budget includes a number of different proposals that would shift higher costs to different kinds of beneficiaries. So as Joe mentioned, there is a proposal that would ask higher income Medicare beneficiaries to pay even higher Part B and Part D premiums. One of the things that's a bit troubling about the president's proposal is that over time, it would expect 1 in 4 Medicare beneficiaries to pay these higher premiums, and the risk is that middle income or middle class beneficiaries would be paying those higher premiums. Another thing the president's budget does is introduce a tax or a surcharge on Medigap plans that provide first dollar coverage. In addition, the president's budget would over time increase the amount of the Medicare Part B deductible. And then finally, the president's budget includes a proposal that would increase co-payments for brand name drugs among low-income Medicare beneficiaries who are enrolled in the low-income subsidy of Medicare Part D or the Extra Help program, which helps low-income beneficiaries pay the cost of their prescription drug premiums and cost sharing.
So I want to go back, and we talked a little bit about this, Stacy, this whole attack on first dollar coverage in the Medigap program. You know, the president has a tax on those policies. You would keep your first dollar coverage, but you would pay more for it. And of course, the House bill, the Doc Fix bill, would get rid of first dollar coverage by including the Part B deductible as a deductible for those plans. And I think what we've discussed, and you know, some of our materials do this, is that we really do believe that first dollar coverage should be a choice for people with Medicare. Right now, you can buy Medigap policies that don't offer first dollar coverage. So if you want a lower premium in your Medigap policy, or you don't feel you need that coverage because you can self-insure for it, you can do that. A lot of seniors particularly, but people with disabilities as well with Medicare, like Plan C and Plan F from Medigap, because once they pay that premium, they are covered in full with first dollar coverage. And I think it's important to note that not only is the savings associated with this that you have to pay a deductible of 147%, but studies show that if you don't have first dollar coverage, typically you use services more frequently. The problem is, and so we say, oh, okay, if you get rid of first dollar coverage, folks won't use the doctor as much. Well, our experience in working with beneficiaries is, first of all, people don't toddle off to the doctor for fun. So it's usually because they have a problem. Then once they do get to the doctor's office, they're either reassured that no, it's not a problem, you don't need other care, or that care is directed them by a doctor. And they really don't have a lot of say. They follow their doctor's orders. And so the problem with getting rid of first dollar coverage is that you tamp down utilization, or you provide a disincentive to utilization, but patients don't know whether that utilization is necessary and appropriate or unnecessary or inappropriate. So we really feel that this first dollar coverage in Medigap should be a choice and should be something that people can pay for and can utilize if they need it. And that even if you increase costs upfront to consumers $5, $10, $15, $20, studies do show it will prevent people from going to the doctor. The problem is we don't know, they don't know, and we don't know if they're not going to the doctor for all the right reasons or for all the wrong reasons. We know they're not going because of cost, which is unfortunate. So I just wanted to kind of get that point across because I said we would. And Mitchell, I don't know if we have any other questions.
We have one more, and it's what are the implications of changes in payments to doctors in the DocFix bill? Do they inadvertently reward doctors for doing less?
So, I mean, that's a good question. And there has been some back and forth between doctors, consumer groups, Congress, etc., over these various reimbursement schemes. And we don't know. What the bottom line is, as these new alternate payment methodologies are being implemented, we will need to monitor them to see if the incentives do actually not align appropriately and might provide incentives for less care as opposed to more care or the right level of care. Right now in the fee-for-service model, there's a lot of talk about how that pays for volume, not value. How fee-for-service provides an incentive for doctors to provide more care. Some of these other methodologies are asking doctors really to provide the right care, not more care or higher value care. But we don't know really if that's going to translate into less care. And maybe less care is good sometimes because we know some care that's unnecessary can be harmful. That said, we don't know all of the implications of this so far. Stacy, any thoughts from you on that?
Yeah, no, I think it is. I just think, as you said, it's critically important that these new systems are closely monitored. And I think another important point is that beneficiaries be appropriately educated about these new models and engaged and sort of have a say in how these different models are rolled out. There is sort of this assumption that all of these decisions about payment and value and quality happen on the back end, and that beneficiaries don't really need to be engaged in that discussion. And I think one thing that we've been advocating really strongly is that you do need to inform and educate consumers and help people understand, what does high value care look like? What should you expect from your physicians, from your hospitals, from your other providers? What should you expect from them in terms of how they communicate with one another about your care? These are really important conversations that beneficiaries need to be a part of, especially now that, if this legislation becomes law, or I should say when it becomes law, there will be over time some really significant changes to the way Medicare pays physicians.
I think that's a very important piece, and we here at Medicare Rights, and many of you who are watching, are committed to making sure that consumers, Medicare beneficiaries, know how to access care and what the incentives are behind the provision of care so that they can look out for themselves. Once again, we know sometimes that fee-for-service can mean that a doctor might want to do an extra test or do extra procedures, and folks are, hey, maybe I don't need that right now, doc. On the other end, we want to make sure that if doctors are holding back or serving as gatekeepers, or others are serving as gatekeepers, that may be appropriate. But we want to make sure consumers know about those incentives, and they know particularly about their appeal rights if they are denied care. And I think that's an important point, that regardless of any system that's used, we're going to be making sure and fighting to make sure not only consumers are aware of what those incentives are and how they may impact them, but also what their rights are if they feel they need something, their physician feels they need something, other healthcare professionals feel they need something and aren't getting access to it through private coverage or through Medicare coverage. And so our mantra will continue to be appeal, appeal, appeal where that's appropriate. So I don't think we have any other questions, and some of them we answered in the course of answering those questions and giving our presentation today. Really appreciate your being here today. Once again, we'll be sending you all an email with some information about how you can advocate with your senator if you feel like doing that. If you don't, that's your call, and some talking points there. And also, we encourage you to be in touch with us, not only through email, but also through our national helpline number. If you have Medicare questions, 1-800-333-4114, or look at MedicareInteractive.org, or MedicareRights.org, where you can sign up for our newsletters or other things if you're not already signed up. Now, most of you are connected with us because you know about this Google Hangout through emails, etc. But if there's another level of involvement that you want to do with us, feel free to go ahead and contact us in one of those ways. So, Stacy, thank you
Thank
in
you.
Washington, and keep eating your Wheaties because you'll need them over the next week. And thank you all again for your attention, for your support, and for really being there for Medicare beneficiaries, not only for the Medicare Rights Center, but the people that count on Medicare itself. Thanks again, and have a great day.
Thank you.